Hello and welcome to the first of a series of lectures covering interpretation of the ECG. My name's Fielder Cam and I'm a cardiology registrar. In this lecture we're going to start right at the beginning and cover some of the fundamentals that you need to know to be able to correctly interpret an ECG. So our learning objectives for this lecture are as follows. 1. Describe an ECG and how we go about getting that ECG. 2. Explain what the difference is between a lead and an electrode. We want to be able to define what waves, segments and intervals are when it comes to the ECG. We want to be able to go through and recognize the elements of an ECG trace and their relation to the electrical activity that's actually occurring in the heart. We want to be able to define exactly what the cardiac axis is and what that looks like on an ECG. And we want to be able to go through from start to finish and interpret a standard ECG. And with that, recognize the features that make up what would be a normal ECG. So what is an ECG? Well, ECG stands for electrocardiogram. It's the same as an EKG, if you ever hear that being talked about often on American TV shows. And essentially it's a surface representation of the net cardiac electrical activity. And this makes it essentially just a complicated voltmeter. But it can seem like a dark art interpreting an ECG. So I think when a lot of people see a standard 12-lead ECG that looks like this, in their mind they see something that looks more like this, something that appears very complicated on the surface. But in actual fact, this is the Rosetta Stone, which was instrumental in allowing people to understand Egyptian hieroglyphs. And hopefully over the course of these lectures, I will help you in developing your skills for ECG interpretation. So what are ECG electrodes? Well, the electrodes are the physical connection between the patient and the ECG machine. And these are the wires and sticky bits that go onto the patient. And there are 10 of these electrodes in a standard ECG. 4 of them go onto the patient's limbs. We have the right arm, left leg, and right leg. And these 4 are color-coded as red, yellow, green, and black. This is an industry standard, and you can remember which one goes where by the mnemonic "Ride Your Green Bike." I'd highly recommend remembering those colors because it's important in an acute medical situation when you want to put somebody on a cardiac monitor to be able to put the leads on in the correct location quickly. The remaining 6 ECG electrodes go across the patient's chest. They are numbered as V1 to V6, with V1 starting at the right sternal edge in the 4th intercostal space, V2 being in the same position in the left sternal edge, V4 is at the cardiac apex in the 5th intercostal space, with V3 unsurprisingly being between V2 and V4, and V6 is in the mid-axillary line in the 5th intercostal space, with V5 being partway between V4 and V6. So how does the ECG actually end up getting generated from these electrodes that are placed on the patient's body? Well, essentially, if there is a current of depolarization going towards the electrode, the ECG machine simply records this as an upward deflection. Whereas if it's a current of depolarization going away from the electrode, then it's a negative deflection. And in more complicated situations where the deflection is going both towards and then away from, for example, you get a positive followed by a negative deflection. And this is how we go about generating the waves that make up the electrical activity of the heart. So in a very simplified example like this, we have depolarization going towards that positive electrode, and that's recorded as upward deflection on the ECG machine. Similarly, in this scenario, again, it's overall going towards the electrode on that right-hand side, and it's recorded as a positive deflection. But as you can imagine, because the angle isn't as head-on as the previous slide, that deflection is less so. And in a situation like this, where it's going perpendicular to that electrode, we have no deflection at all. Now, in reality, the electrical activity of the heart is much more complicated and looks something more akin to what we have here, with signals going in many different directions across the heart. And so we have to try and work out what the overall signal would be here. And in the case of the heart, what we do is we take the net signal. That's all the ECG is able to take, because it's taking the signal from the surface. So it takes the net electrical activity, and all of the electrical activity here can be considered like a set of vectors. And when we combine vectors together, we put them end to end, and we get an overall picture. And as you can see here, overall it's going towards the electrode, and so there is overall a small positive deflection. So what are leads and what are electrodes? Well, we've talked about electrodes. They're the physical connection between the ECG machine and the patient. So what about leads? Well, leads are essentially an imaginary line that connect two or more electrodes together. And it's between those electrodes that we measure the difference, which gives us that deflection on the ECG machine itself. So we take the electrodes on the limbs and we can create a number of leads from them. So if we take the three main ones, so we take the right arm, and left leg. The right leg is actually used as a neutral lead that's used to sort of provide a baseline for the ECG, so you can ignore that when you're thinking about how the leads themselves are generated. Now, if we measure one from the right arm across to the left arm, you can imagine that goes straight across the patient's body, or the patient's heart, in fact, and goes straight out the left-hand side, and that's lead 1. We can take one from that right arm down to the left leg, and you can imagine that going sort of diagonally down from top right to bottom left, and that would be lead 2. And similarly, we can take one from the left arm to the left leg, which does the opposite, going diagonally down the other way. And we can combine those electrodes in a couple of other ways, and overall we end up with our three original ones that we've just discussed, and these are like part of our Vitruvian man that you can see on the right hand side here. So you can imagine lead 1 going straight out of your left arm, lead 2 going down your diagonal left leg there, and lead 3 going down your diagonal right leg. And we can create 3 augmented or average leads. Unfortunately, the naming of them makes it easy to identify because they all start with AV. And so you can get an average lead on the left-hand side, which goes up at your sort of diagonally outstretched left arm, a augmented or average right lead, AVR, that goes up your diagonally outstretched right arm, and then AVF, which goes straight down to the floor or to your feet, which is what the F stands for. And those would be the 6 leads that come from your 4 limb electrodes. Now, the remaining 6 standard ECG leads that come together to make the 12 lead ECG are looking at the heart through the axial plane, as opposed to those original ones which were looking through the coronal plane. And they're very simply named V1 to V6. We have V1 and 2, which look primarily at the septum between the left and right ventricle. V3 and V4, which are supposed to be looking at the anterior wall of the left ventricle. And V5 and V6, which look at the lateral aspect of the left ventricle. And you'll notice that these names of the leads are the same as the names of the 6 electrodes that go across the chest. So having talked already about the electrodes and leads in regards to the ECG, I think it's now time to talk to you about the waves and segments that make up a standard ECG and are the standard representations of the electrical activity within the heart. So these are essentially the squiggles that you see on the pink paper. So I must start by apologising for the crude drawing of a heart on the right-hand side of the slide. I'm afraid that you'll see this many times during the course of this lecture series. And it's very clear that I was never going to be an artist. Now, the electrical activity in the heart, when it's having a normal heartbeat, starts in the sinoatrial node, which is at the superior posterior aspect of the right atrium. And just as that signal starts there, on the left-hand side, you can see that there's a flat line on the ECG because there's no real electrical activity in the heart. It's ready to depolarize. The signal starts in the sinoatrial node and it spreads across the left and right atria, and the atria depolarize. And that depolarization is represented by a humped deflection on the ECG, which is the P wave. The signal then reaches the AV node, the atrioventricular node, and one of the major functions of the AV node is to hold that signal, which allows time for the atria to contract to help fill the ventricles before the ventricles depolarize and contract themselves. Now, the signal is moving through the AV node, but the AV node is a relatively small amount of tissue, and the amount of deflection that you see on the ECG is proportional to the amount of tissue that is electrically active at that period of time. And so as there's very small amount of tissue changing electrical activity, the period of time while it's in the AV node is flat normally on an ECG. Now, we combine the period of time that the P wave is occurring and that flat period while it's in the AV node, and we call that the PR interval. And we can talk about that time just while it's flat from the end of the P wave to the beginning of the next wave that you see as the PR segment. Once the signal's got through the AV node, it then goes through to depolarize the ventricles. So it goes through the His-Purkinje system to do that. And what we see is this relatively large set of deflections, which are made up of several waves called the Q, R, and S waves. And together those are considered the QRS complex. Now, the R wave is always the first positive deflection of this group. And you'll notice that they look very sharp compared with the P wave, so they're difficult to confuse between the two. So you have the first positive deflection being the R wave. Now, the next negative deflection that occurs after an R wave is an S wave. Now, if you have a negative deflection first, so before that positive deflection, before the R wave, then that is called a Q wave. But a Q wave never comes after an R wave. Everything is alphabetical. So you only have a Q wave if the first deflection of this QRS complex is negative. And I think that's important to remember because Q waves are important in some cardiac pathology, which we'll discuss in future lectures. Now, after the initial deflection of the ventricles, you may remember that ventricular muscle cells have a plateau phase, and this is while ventricular contraction is normally occurring. And this plateau phase, there's not much change in electrical activity occurring during this time, so the ECG records this as a flat line normally. And this is called the ST segment. So it's the gap between the QRS complex and the next wave, which, as I'm sure you can imagine from the naming, is called the T wave. And this T wave represents ventricular repolarization. Now, the T wave, as you can see, is humped similar to the P wave, so it's difficult to confuse it between the QRS complex. Now, you may be asking yourself, well, what about atrial repolarization? And atrial repolarization is a relatively small amount of electrical activity. It's relatively diffuse, and so you often don't see it on a surface ECG. And from a timing point of view, it often occurs during the time that the QRS complex is occurring, so it's normally not seen. Now, The gap between the beginning of this QRS complex and the end of the T wave is called the QT interval. And this is important from the fact that it can be associated with significant arrhythmic risk if it's prolonged. And we talk about that in a future lecture as well. Now, occasionally after the T wave, you'll see another deflection. And because everything is alphabetical as much as possible in the ECG, after T comes U. And so this next wave is called a U wave. And this is thought to represent repolarization of the Purkinje fibers. And normally this is of no significant consequence. Although if it starts to get big relative to the T wave, and normally we say more than about 1/3 of the size of the T wave, then that can be representative of some electrolyte abnormalities. So that's the sort of makeup of a standard heartbeat as represented by the surface ECG. So we've talked through a standard heartbeat on a surface ECG, at least electrically. But what are waves and what are segments? Well, a wave is any sort of purposeful deviation from the baseline, and it represents a change in electrical activity in the heart. And so we have the standard waves in a surface ECG, which are a P wave representing atrial depolarization, the Q, R, and S waves in various combinations, which represent ventricular depolarization, and then the T wave, which represents ventricular repolarization. We have segments, and segments are that sort of flat region, or what should ideally be flat, but sometimes isn't, between two waves. So it's the gap between the end of one wave and the beginning of the next wave. And particularly, we tend to talk about the ST segment, which is from the end of the QRS complex and the beginning of the T wave. And sometimes we can talk about other segments, particularly the PR segment from the end of the P wave to the beginning of the QRS complex. And intervals, which we've also discussed on the previous slide, are a segment and then at least one wave. And so particularly we tend to talk about the PR interval, which is the P wave, and then the PR segment together, and they form the PR interval. And we also talk about the QT interval, which is the QRS complex, the ST segment, and the T wave, all combined together to create that QT interval. So what is the cardiac axis? I think this is a concept that confuses a lot of people when they start learning about the ECG. And hopefully I'll be able to persuade you that it's something actually relatively simple. So in general, when we're talking about the cardiac axis, what we mean is the net vector of depolarization. And that's really just the net direction in which the heart is depolarizing. Now, most people, when they talk about cardiac axis, think of it synonymously with the ventricular axis. So that's the direction in which the ventricles are depolarizing. And so really we need to talk about the QRS complex because that represents ventricular depolarization when we're talking about cardiac axis. However, you can also talk about the atrial axis, so the direction the P waves are going in, or the axis of ventricular repolarization, so T waves. But I think it's sufficient for our purposes to really think about cardiac axis being synonymous with the axis of ventricular depolarization. So here's a simple drawing of the heart, and as I'm sure you can appreciate, the signal for ventricular depolarization starts in the AV node and works its way downwards. And so the net direction of ventricular depolarization tends to be downwards, and there's more muscle in the left ventricle than the right. And as I mentioned earlier, the amount of cardiac muscle is sort of somewhat determinant of the amount of deflection you see on an ECG, although that is not always the case, but in general it is. And so we have a big left ventricle, so we have depolarization going from top right down to bottom left. And that's the normal axis. Now, obviously there's a significant amount of individual variation, and so it's been defined, having looked at this in many different people, that the normal axis is about 120 degrees in size and is along this sort of general top right to bottom left direction. Now, if we map this onto a grid, like I have here on the right, we can see it looks something like this. And unfortunately, the person who designed this grid decided that 0 degrees would be straight out to that right-hand side. And so a normal axis goes from -30 to +90 degrees. Now, deciding if the cardiac axis is normal is actually very simple. I appreciate that many of you, having started to learn about the ECG, may have been told many different ways of doing this. And if you have a way that works for you, that's absolutely fine. But hopefully I'll be able to persuade you that it's very simple, and there's certainly a very simple way of doing it. So we know that anything that's too far round to this left-hand side is left axis deviation, and anything far round to this right-hand side is right axis deviation. Now, if you have a net direction of depolarization that's completely opposite of normal in this sort of top left section, that tends to be called northwest axis, or sometimes you'll hear it being described as extreme axis, and that's very uncommon and should be something that you look into acutely. Now, what we have to remember when we're thinking about cardiac axis and trying to work out what the axis is a simple thing, which is, as I said before, if something is depolarizing, if the ventricle is depolarizing towards a lead, then you'll have a positive deflection. And so we can take a couple of leads to work out what the axis looks like. So if we take lead 1, this looks straight out to the left at 0 degrees. So if we have a positive deflection in lead 1, we know it must be coming in some way towards that lead. And so we can get rid of the axis being anywhere on that left-hand side of the graph. So that's very useful. And if we take lead 2 looks down at about 60 degrees. And so again, if it's positive in lead 2, we know that anything to the top left of that dotted line, it can't be going in that direction. So if it's positive in lead 2, it must be coming down to the bottom right. So if it's positive in both of these leads, the axis must be normal. Now, if you would have left axis deviation, so up on the top right in the case of this graph, then normally lead 1 would be positive and lead 2 would be negative. And if you had right axis deviation, which is down at the bottom left of this graph, then you would have normally a positive lead 2 and a negative lead 1. So now that we're able to interpret the cardiac axis, it's probably worth having a rough idea of some of the major causes for axis deviation. So right axis deviation is when the cardiac axis comes right round towards the bottom right. So it's positive in lead 3, for example, but likely to be negative in lead 1. And unsurprisingly, that's caused by pathology on the right-hand side of the heart. And in particular, right ventricular hypertrophy, so bulking of the muscle of the right ventricle is a common cause for it, as is right bundle branch block, or anything that causes a degree of pulmonary strain, for example, large pulmonary emboli. And another cause is pre-excitation. This is something that we'll discuss in a later lecture in much more detail, but essentially that's an extra electrical connection between the atria and the ventricles, and that extra pathway can change the shape of the QRS complex. And if it's in a particular location, then it can cause right axis deviation. Left axis deviation, being somewhat the opposite of right axis deviation, is caused by an opposite set of things. And particularly it's caused by left ventricular issues, so left ventricular hypertrophy, left bundle branch block, pre-excitation again if that accessory pathway is in a particular location, and some forms of congenital heart disease. Those would be the big ones to talk about. There are many others. We mentioned before this idea of northwest or extreme axis, and this is something to be taken seriously, particularly because it can be a sign of a very significant set of cardiac rhythm disturbances, particularly ventricular tachycardia or ECG changes in keeping with quite significant hypotassium, hyperkalemia. It can also be a feature of very severe right ventricular hypertrophy. You can imagine that that is just very bad right axis deviation becoming northwest axis. But actually the most common cause for it is that the person recording the ECG has accidentally put the left and right arm leads on the wrong way around. And so if you go and see the patient and they look very well, the first thing I would do is ask for another ECG, and I would just ask whoever is doing it, or do it yourself, to very kindly just check that those arm leads are on the correct way around. So, how to actually read an ECG? I'm hopefully going to persuade you over the next few slides that taking a very systematic approach to the ECG is the key to ECG interpretation. Now, as you get more experienced and you see more and more ECGs, much of ECG interpretation will become pattern recognition. But I think it's very important to have a planned route through interpreting the ECG to fall back on for when that pattern recognition fails. So I think the best place to start is with the details. So name, age, date, and any indications for the ECG. Now, often in clinical practice, you'll probably know most of this because you'll have gone to see the patient and then asked for the ECG. But in an exam setting, you may not have that information previously to hand, and this can provide useful information. For example, if the patient's complaining of chest pain, it's very different to if they're complaining of palpitations potentially. After you look at the details, you then need to look at the technical aspects of the ECG. So is the ECG calibrated correctly? Now, this can be done quite simply by looking at this little rectangle that will either be on the left or right hand side of the ECG. And this is the calibration area. And essentially what the ECG machine does is it generates a single millivolt for 1/5 of a second. And what that does is it should cause a 2 large square deflection for that 1 millivolt. Okay, so 10 millimeters per millivolt. And the ECG machine goes at 300 large squares a minute, or 25 millimeters, 5 large squares per second. And so because it does it for 1/5 of a second, that rectangle should be 1 large square wide. Now, unlike a chest X-ray, which is either calibrated correctly or incorrectly, so it's either rotated or not, it's either got correct penetration or not, with an ECG, it's just whether it's calibrated normally. So it would normally be calibrated to a paper speed of 25 millimeters a second and a sensitivity of 10 millimeters per millivolt. But there are reasons for setting those settings to different levels. And I think it's just important to interpret the ECG in light of how it is technically calibrated. So having dealt with those initial aspects of ECG interpretation, making sure you know who it's for and why they've done it, as well as knowing how the ECG is technically calibrated, we can then move on to look at the rate. And that's how fast the heart is going. And really we're talking about the ventricular rate in most situations. And there are a couple of ways of determining the ventricular rate. One is to say, well, I know that a normal ECG, if it's calibrated normally, the machine goes through 300 large squares in a minute. And so I can count up the large squares between two R waves, the RR interval. And I can count that up in large squares, and I can take 300 and divide it by the number of large squares, and that will get me the heart rate. And we can show that here. So we take a standard rhythm strip for an ECG. We'll take 1 or 2 complexes here, and we can show that that's 5 large squares across. So 300 divided by 5 is 60. So this heart rate is 60 beats a minute. Now, another option would be to say, well, I actually know that the ECG takes 10 seconds to go from start to finish. Standard ECG does. And so there are 60 seconds in a minute. So I could count up the number of complexes I see over these 10 seconds and multiply them by 6. We can see that here there are 10 complexes, so multiply by 6 is 60. And so you can see that in most situations these give similar results. Now, I think once you get used to doing it, certainly the 300 divided by the RR interval is a very quick way of getting an approximate heart rate, but it does fall down when the gap between complexes changes, so when the rhythm is not regular. And in that situation, counting up the complexes and multiplying by 6 may be more helpful. You can see this is 60 beats a minute as well. So once we've done the rate, we then go on to the rhythm. And the question is it regular? So are the QRS complexes occurring at the same point that you would expect them to after the preceding one? And are there P waves before each QRS complex? So when we're saying are there P waves before each QRS, we're saying is the electrical activity of the ventricles being triggered by electrical activity of the atria, which is what's supposed to happen. So we can see here that the gaps, these arrows are the same, so the gaps between R waves is the same. And we can see as well that there are P waves before each QRS complex. And the same gap between these R waves, and actually, although I can do it here on my presentation with arrows, often the easiest thing to do in a clinical setting is to get a piece of paper, mark the R waves between a couple of complexes, and then move them along to see if they're the same. And that can be particularly useful if the heart rate is quite high. Now, I think it's important to talk about sinus rhythm here. So sinus rhythm is a term that we use when we're saying that the heartbeat is being triggered by depolarization in the sinoatrial node. Now, a lot of people use that term when they simply see a P wave followed by a QRS complex. But that's not truly the case. All you're seeing there is that there's atrial activity followed by ventricular activity. But just because there's a P wave, it doesn't tell you where in the atria that depolarization is starting. So to say that it's sinus rhythm, we really need to say, well, actually, does this look like it's coming from the sinoatrial node? And to tell that, we need to go back to our schematic of the heart and remember that the sinoatrial node is at the sort of upper outer aspect of the right atria. And so unsurprisingly, the depolarization coming from the top right to depolarize across both atria must go towards the bottom left. And we can see that with this arrow here. And the ECG lead that's looking towards that bottom left is lead 2. And so we say that for it to be sinus rhythm, the P wave really needs to be positive in lead 2. And so that's something that you should look for when you're going to comment on whether you think this is sinus rhythm. So not only should P waves precede each QRS complex, but the P wave should be positive in lead 2. So we've talked about rate and rhythm, and so now we're going to talk about axis again, and hopefully you're all much happier with cardiac axis at this point. And so this is our net direction of depolarization. And so here's our example ECG. And so as we talked about before, we're going to take leads 1 and 2, and we're going to take our little graph here. We're going to take lead 1 to start with, and we can see that overall the direction of that QRS complex is positive. So we know that it's coming towards lead 1. So we can get rid of everything on that left-hand side. We can do the same with lead 2 here, and we can see down here lead 2, the QRS complexes are predominantly positive. And so we know it's coming towards lead 2, so we can exclude everything at that top left-hand side. And so because we know it's positive in lead 1 and lead 2, we can get rid of this whole area of red, which leaves us only the normal axis. So we know that the axis is normal. So having done the cardiac axis, that's the last of sort of the global features that we need to look at on the ECG, and we can now go through it alphabetically. So we can start with the P wave, and as we've just mentioned previously, that should be positive in lead 2 in sinus rhythm. In addition to that, we have some criteria for how wide the P wave should be and how high it is. And it shouldn't really be more than 2.5 millimeters, so 2.5 small squares high, or 3 millimeters wide. If it's higher than that, then that suggests that the right atria is dilated. And if it's wider than that, it suggests the left atria is dilated. And so those are features that you really can pick up from the P wave. And so I'll show you. We take our ECG trace that we've used previously, we take out our complexes here, and we can see that we've got a P wave that's about maybe 1.5 small squares high, and it's about 2.5 small squares wide, so a pretty normal looking P wave. And we can compare it with this P wave here, and we can see that actually this is much higher. We're looking at 3, maybe 4 millimeters high, and in terms of width, we're looking probably at about 3 to 3.5 millimeters wide. And actually it's so wide that you can start to see a notching in that P wave, so it doesn't look like a normal hump. You can see there's 2 peaks to it, and that's normally called P mitrale. And it's called mitrale for a couple of reasons. One, it represents problems with the left atria, so mitrale for the mitral valve, but also the P wave looks like an M, which is helpful to remember. You may hear P pulmonale being described for waves that are P waves that are too high, and that's because it represents a right-sided problem, so a pulmonary valve problem often. So having done the P wave, we're now going to look at the PR interval, and as you may remember from before, that's the P wave plus that PR segment, the gap between the end of the P wave and the beginning of the QRS complex. And this represents atrial depolarization and then the time the signal takes to get through the AV node. And we use the PR interval in this situation to look at the AV node. And we don't use the PR segment primarily because although that represents time that the signal is just in the AV node, you can imagine that the signal may get to the AV node while the depolarization of the atria is continuing. And if you had a big left atria causing a wide P wave, that may make the PR segment look shorter, even though there's been no change to the AV node. And our normal duration for the PR interval, so the P wave plus the PR segment there together, is 120 to 200 milliseconds. Now, each small square represents 40 milliseconds, and so that's 3 to 5 small squares. So we can take our ECG tracing we've looked at before, and here we take from the beginning of the P wave to the beginning of the QRS complexes in each situation here, and that looks to be about 4 small squares, so about 160 milliseconds. And we compare that here to this complex, and we can see that actually the beginning of the P wave to the beginning of the QRS complex looks much shorter. In fact, it's probably only about 2.5 small squares, so 100 milliseconds. So that suggests something is bypassing the AV node in this situation. And this ECG complex shows that the patient probably has an accessory pathway, that extra communication between the atria and the ventricles. So having looked at the P wave and the PR interval, we now move on to the beginning of the QRS complex. And the first thing to look at with the QRS complex is, are there any Q waves present? Now, these Q waves can either be physiological or pathological. And the Q wave here is this little bit, and it's this downward deflection before any positive deflection. So the first positive deflection of the QRS complex is called the R wave. And so Q waves are only present if there is a negative deflection before any positive deflection. Okay, so if there's an R wave first, the downward deflection after that is an S wave, not a Q wave. Now, whether they're physiological or pathological is really determined by size and a bit by patient history. So if they're narrow, less than a small square, 1 millimeter wide, and they're shallow, so less than 2 millimeters deep, then they may well just be physiological Q waves. And so we take our same tracing again. We can actually see here that we have very little Q waves, and these are entirely physiological. And we can compare them to this trace here, which shows quite deep Q waves, and these are pathological. And actually, given that this patient also has upside down, inverted T waves, it's probable that these relate to a prior myocardial infarction. So having looked at the Q wave, we should now go on to look at the rest of the QRS complex. And we've described that this represents ventricular depolarization. And ventricular depolarization uses the His-Purkinje system, which is dedicated electrical tissue. And as such, it should act like a superhighway, allowing for very quick ventricular depolarization. And so the QRS complex should be narrow. And the upper limit of normal is normally considered to be 3 small squares, 3 millimeters wide, which is 120 milliseconds. Although you will, in some places, see it described that truly normal is less than 2.5 millimeters wide, so less than 100 milliseconds. And that portion of time between 100 and 120 milliseconds, if that's what the QRS complex looks like, represents some degree of partial block of the His-Purkinje system. So we can take our electrical tracing again here, our ECG, we can blow up our complexes, and we can show that actually here we've got clearly very nice narrow QRS complexes, so a normal QRS duration. If we compare this to an ECG tracing showing left bundle branch block, we can see that these are quite broad QRS complexes, probably in the region of about 160 milliseconds. So the other aspect, apart from breadth of the complexes, is amplitude, height of the QRS complexes. So how high are they? Now, height of the deflection, as we've said, represents the amount of electrical signal, and so is a proxy for the amount of muscular tissue that is depolarizing in this case. And so what we're really saying is the left ventricle too big? The left ventricle makes up the majority of the muscle mass for the ventricular depolarization, so it is the primary driver of QRS amplitude. If we simplify things quite significantly, we can talk just about the lateral wall and the septal wall of the left ventricle. And so in ECG terms, really the septal leads, as we've mentioned before, are leads V1 and V2. They look just at that septum of the left ventricle, and we compare that with V5 and V6, which look at the lateral wall. And actually, we can make things simpler still and just say, well, we'll just use V1 to represent the septal wall and V6 to represent the lateral wall, or the lateral aspect of the left ventricle. So how does this work in practice? Well, here's our ECG tracing in full. If we take our V1 and V6, what we want to know about is, in V1, how big is the negative deflection? So if you recall, V1 comes from that right-hand side of the chest, so it's looking at the ventricle from that right-hand side, and the ventricle depolarizes from right to left. So that left ventricular depolarization is going to be occurring primarily away from V1. And so we're interested in that negative deflection, which represents that left ventricular depolarization, and that negative deflection is the S wave in V1. So we take that, and then we look at V6, and V6 is in the mid-axillary line on that left-hand side, and so it's looking at the left ventricle from that left side, and it will see the ventricle depolarizing from right to left towards it. And so because it's occurring towards it, it'll be a positive deflection in V6. And so we want to take the R wave in V6, and we add those two together, and the cutoff point that's been set is 35 millimeters. That's 35 small squares, or 7 large squares, and we say that that is suggestive of left ventricular hypertrophy. So we can take these complexes here and we can say, well, there's about 7 small squares in that S wave. There's about 11 small squares in that R wave. And so that's clearly less than 35, being 18 millimeters in height. So having done both the breadth and amplitude of the QRS complex, we can now move on to look at the ST segment. And this represents the ventricular plateau phase. And as you can imagine, as you may have been told, this should be flat. It should be a flat line, and it should be isoelectric. And what we mean is sort of at the baseline level. So it's not deviated either up or down from that point. And we can compare that to primarily the PR segment, so that gap between the end of the P wave and the beginning of the QRS complex. So we can look here, you can see the ST segment on the surface ECG, and we can compare that with the action potential within a ventricular myocyte. And we see this QRS complex in purple, and on the action potential, this represents the rapid depolarization and initial repolarization, and you can imagine this occurring in many ventricular cells across the ventricle. And then the point between the end of the QRS complex and the beginning of the ST segment, that is what is referred to as the J point, the J meaning junction. And this is important because that's the point that you should measure the ST segment deviation from. And we'll talk about that again in the next lecture when we talk about ischemia and infarction, where this becomes important. And you can see this ventricular plateau phase in yellow, and that is the ST segment that we see on the surface ECG before the ventricular repolarization in red, represented by the T wave. So now we know what the ST segment represents. I think it's important to have an idea of how much deviation from the baseline is clinically significant. The traditional way of thinking of this is that in the chest leads, and by that I mean leads V1 to V6, you need at least 2 leads that are next to each other with at least 2 millimeters of either elevation or depression in each. And that in the limb leads, so that's leads 1, 2, and 3, and then the augmented leads, that again you need 2 leads that look at similar areas of the heart, and each of them needs to have at least 1 millimeter. Now, the most up-to-date guidance suggests that actually 1 millimeter of elevation is sufficient in at least 2 leads, everywhere except for leads V2 and V3, which still need 2 millimeters. But everywhere else, as long as you've got 2 concordant leads, 2 leads that are next to each other showing at least 1 millimeter of elevation, that is sufficient to say that there is significant ST elevation. And I think the key thing is that we use the leads on the ECG to look at different vascular areas around the heart. And broadly, there are 4 vascular areas: septal, anterior, inferior, and lateral. I'm not going to go into which leads represent each of those areas now, because I'll cover that in a lot more detail in lecture 2. So, now that we've done the ST segment, we're on to the T wave. And as we explained before, the T wave represents ventricular repolarization. And broadly, it should go in the same direction as the QRS complex. So if in a particular lead, the QRS complex is predominantly upright, i.e. the R wave is greater than the S wave, then the T wave should be upright. But in leads where the QRS complex is predominantly downgoing, in particular that tends to be leads AVR and V1, then actually it's very normal for the T waves to be inverted there. And indeed in lead AVR, the T wave should be inverted. And as you can see here, we've got our trusty ECG back. And you can see that all of the T waves are upright, except for here we've got AVR and V1, where we've got clear T wave inversion, and the T waves are going in the same direction as the QRS complex. So we've now got to the end of our PQRST run through, and what's left is to assess the QT interval. And as we've said, this is representative of the entire period of ventricular depolarization, because we start timing it with the fast, rapid depolarization that you see at the QRS complex, through the plateau phase, and then through to the end of ventricular repolarization, represented by the T wave. And as that increases, if the QT interval increases, that's associated with increased arrhythmic risk. And the duration of systole in the heart is associated with the heart rate. As the heartbeat increases, the systolic duration decreases. And so what counts as a prolonged QT interval, or what counts even as a normal QT interval, is dependent on the heart rate. And so you have to take that duration from the beginning of the QRS complex to the end of the T wave and correct it in some way for the heart rate. And the normal corrected values are displayed here. So it's less than about 450 milliseconds for men and less than about 470 milliseconds for women. And generally less than 500 milliseconds, the chances of having quite significant arrhythmic risk is low. So how do we go about measuring the QT interval? Well, we take our QRS complex and our T wave, and that bit's easy. But the question is, where does the T wave end? Well, the best way to assess this is to use something called the tangent method. And what you do is you draw a straight line from the sort of maximum deceleration of the T wave, and you see the point that that intersects with the baseline. So you can see that I've drawn the horizontal baseline here and a diagonal tangent line. And it's at that intercept point that that's where the T wave is described to end. And this is the best way of ensuring that you are constantly measuring the T wave in the same way. And that's how we get our QT interval. And as I said, you have to correct for the heart rate, and there are several formulas to do this. But what we have here is our example ECG again. We can take our QT interval. That's 10 small squares, which is 400 milliseconds. And this is our RR interval, so essentially proportional to our heart rate. That's 29 small squares, and so that works out as 1.16 seconds, because there's 25 small squares in a second. And Bazlett's formula is probably the most well known, and so what you do is you take that raw QT interval, the 400 milliseconds, and you divide it by the square root of that distance between the R waves, the RR interval, in seconds. So we take our 400 and divide it by the square root of, in this case, 1.16, which is what I've shown here, and what we end up with is 371 milliseconds. So certainly not prolonged. So that brings us to the end of this lecture, and I'll just go through the learning objectives again, just so that we can show that we have covered them. But we've gone through and described what an ECG is and how we go about getting those electrical signals from the heart. We've explained what a lead is and what an electrode is, and hopefully you won't confuse those two again. We've gone through and defined what a wave is, what a segment is, what an interval is, as well as describing the individual waves, segments, and intervals that are of importance when interpreting the ECG. And we've related that ECG activity to what is electrically occurring within the heart. We've talked about cardiac axis and what that means in terms of the ECG, and how you can simply use leads 1 and 2 to interpret that. We've gone through from start to finish with a method for reading ECGs. And we've gone through what the normal parameters are for an ECG as well. And so hopefully this gives you a good grounding for interpreting the ECG. And in later lectures we can move on to slightly more interesting stuff, including some pathology that we can interpret. So this is the point of the lecture right at the end, where I would normally open up to the audience and ask if there were any questions. Of course, that's a little bit more difficult with a pre-recorded lecture, but I'm sure there will be questions that come up. There'll be bits that I probably haven't explained as well as you might need. There'll be bits where it's still a little bit confusing. And if that is the case, then these are my email addresses. Feel free to email me. I'm very happy to take questions, and I'll try and get back to you as quickly as possible. And I'm also on Twitter, so feel free to contact me that way. But otherwise, I look forward to seeing you in lecture 2, and hopefully you found this lecture enjoyable.